Ensure safe surgery. This international patient safety goal is meant to avoid surgery to wrong patient or body part. This is usually done by a preoperative checklist, marking the surgical site, timeout just before the surgery or procedure, and sign out just after the surgery or procedure. Surgical and invasive procedures include all procedures involving an incision or puncture, including but not limited to open surgical procedures, percutaneous aspiration, selected injections, biopsy, percutaneous cardiac and vascular diagnostic or interventional procedures, laparoscopies, and endoscopies. Significant patient injury results from wrong site or wrong procedure. Such events can result from ineffective communication between members of the team conducting the surgery or invasive procedure. In addition to inadequate patient assessment, inadequate medical record review, illegible handwriting, and use of abbreviations. The approaches the hospital takes to ensure safe surgery applies to all areas of the hospital in which surgical and invasive procedures occur. The Universal Protocol uses multiple strategies. These are the preoperative verification process, marking the surgical site, and timeout that's held immediately before the start of the procedure. In this timeout, we usually verify the correct patient, correct procedure and site, and ensure that all relevant documents, images, and studies are available, properly labeled and displayed, and verify that any required blood products, special medical equipment, and or implants are available. Preoperative verification process. This process is to make sure that all relevant documents and related information or equipment are available prior to the start of the procedure, correctly identified, labeled, and matched to the patient's identifiers, and reviewed and are consistent with the patient's expectations and with the team's understanding of the intended patient, procedure, and site. These relevant documents are at a minimum relevant documentation, for example, history and physical, signed procedure consent form, nursing assessment, and pre-anesthesia assessment, labeled diagnostic and radiology test results, and any required blood products, implants, devices, and or special equipment for the procedure. Don't wait until the timeout to complete the preoperative verification, but complete it before the patient arrives at the preoperative area. Portions of this verification may occur more than once and in more than one place. Marking the procedure site is usually done when there are more than one possible location for a procedure. For example, different limbs, fingers and toes, level of spine, and bilateral organs. If we remove bilateral structures as tonsils or ovaries, no need to mark. Marking should involve the patient and is done with an agreed upon mark. Don't use X mark. Marking is done by the person who will perform the procedure. In case of surgery, the responsible surgeon is the one to do the marking. In non-surgical invasive procedures, it may be a physician who will do it. A trainee may perform the marking if he or she performs the entire procedure without supervision. Site marking may take place any time before surgery or procedure, as long as the patient actively involved and the mark is visible after the patient is prepped and draped. Adhesive markers are not recommended. The patient may not be involved when he or she is not competent, for example, children, and when urgent surgery is required. Examples of other situations that involve alternative process include minimal access procedures treating a lateralized internal organ, whether percutaneous or through a natural orifice. Interventional procedure cases for which the catheter or instrument insertion site is not predetermined. Teeth. Premature infants for whom the mark may cause a permanent tattoo. Each hospital determines the best time for verification and site marking. Timeout. Should be held immediately before the start of the procedure. The team should agree on correct patient identity, correct procedure, and correct site. Timeout allows any unanswered questions or confusion to be resolved with participation of all team members. After timeout, no one from the team leaves the room. Timeout should be documented. When patient performs more than one procedure at the same setting by different persons, repeat timeout before each procedure. Sign out before patient leaves. Sign out includes confirmation of the following: name of the surgery or invasive procedure that was recorded, completion of instrument, sponge, and needle counts as applicable. If we take a specimen, labeling of the specimen should be read aloud, including patient name, and any equipment problem to be addressed. Use quality control to monitor compliance with the protocol, for example, indicators. If wrong patient, wrong site, or wrong procedure done already, as a medical legal case must be handled carefully and reviewed by the surgical case review committee as to how things happen. An OVR must be filled by the charge nurse and concluded by the surgeon. And a thorough investigation should be conducted involving all included medical staff. Thank you.